I think we are very punctual in our meeting, so that let's start the meeting actually. So good evening, all. Today is a 47th presentation. On peculiar cases in renal transplant. Today is unique to my knowledge because we have a different presentation. Thagapandi, Kailangovan is joined or not?
Sir, joined, sir.
Yes, sir, joined.
Okay,
Thank
okay.
you. Hello, sir.
Yeah, a little worried actually. You are the medical and the other surgical case. The combination is very crucial today. So okay, today again, good evening to one and all. And today we have two interesting presentation. My introduction will be very informal because I know them well, and most of the people except Murli, the whole peculiar case members might be knowing everybody here. So it's a very brief introduction about the speakers. First. I think we are going to introduce Dr. Ilangovan Veerappan. Who's going to present? Nagendran or you, Ilangovan? Who's going to present first?
Nagendran.
Okay. Now, so first speaker, we have lined up two cases today. One is a surgical case, one is a medical case. And surgical case by Dr. Nagendran. He's a graduate from PSG Medical College, Coimbatore. Then he did a MD graduation in Manipal, then Kilpak Medical College in Tamil Nadu. Then after that, he's in Erode. It's a city in a big city in Tamil Nadu, where he has been very passionately doing kidney transplant. So in his encounter, he has seen. This is the first of kind for me, and even 24 years of practice. This is a very complex case. He had even discussed with me, and he has ventured and he has succeeded, and with great precision. So that's what he's going to present. The journey is very remarkable, and it's a learning point for everyone who are assembled here. And we have the person who has done the surgery is with us as a panelist. Is going to add some kind of a new kind of a perspective to this surgical innovations and how we can move forward in the similar cases. And we have a second presentation by Dr. Ilangovan Veerappan. In my simple opinion, he is a truly out-of-the-box thinker. Whenever I meet him, he gives some kind of rekindle my ideas. He always says that we have knowledge, but there is some gap always find implementing it. So that's what is going to fill the gap by his, he thinks the conventional into the creative kind of thing, wherein we can pay attention because we see acute antibody mediated rejections are known to everyone. So his perspective, so he's very different today, and he's just going to reiterate a point or reinforce a point wherein we might ignore, and later we find that the patient developing de novo antibodies and we're losing the graft in the long run or in the short run. So that's why he's going to look at it in a different angle, and is going to his presentation is going to be unique and very different. And I'd like to ask Dr. Ilangovan to pause slides with more of a, your ideas should be imparted to everyone. Take your time and don't rush through the slides. And we have to learn from a lot of things from you today. And we have a very, it's a distinct honor for me to introduce to the panelists here. One is a veteran nephrologist, Dr. Ramalingam sir. He's a very influential person in terms of advancing the knowledge of the renal medicine in this field. He's 3 decades and plus his practice is not only pioneered in the renal medicine, but also helped many students achieve knowledge in this field. His knowledge is unparalleled, and this is the third time he is appearing on this platform. And welcome you, sir, for your. And we have another young, dynamic, very, very, very surgeon. Is close to our heart in this area of Tamil Nadu. He is assistant professor in Tanjore Medical College. He's a vascular surgeon. See, in a complex, transplant is a complex symphony, right? It's not an easy surgery in some cases. We need to have a good architect to, create, give a complete precision and foresight into that, particularly on table. So he's been instrumental in developing many transplant surgeries taking up in a big way in his own institution in Tanjore Medical College, in and around institution like Nagendran. Nagendran is batchmate of Dr. Murli. He calls him, he travels long distance from Tanjore to Erode, at almost is covering 200 kilometers to execute the precision what he requires from what we expect from any vascular surgeon. That's what the association has developed with everyone. In my opinion, skin to skin, he can complete the surgery. He has been exposed to that kind of complexity in renal transplant. I mean, especially in all complex vascular surgical case. Welcome, Murali. And without much ado, I think I'll just ask Dr. Nagendran to start the presentation. Go slowly, and any video description, make a please complete anatomical knowledge you have to give us today, because the picture may not be clear, but your description should be very elaborate to make us understand the things very clearly. Thanks, Nagendran, for accepting this invitation. Please go ahead.
Okay. Thank you, sir. Thanks for introduction, sir. Good evening to everyone. Thanks for giving me this opportunity to present in this forum. Today, we are going to see one peculiar case. I'm going to present a CKD with the bilateral iliocaval thrombosis, a clinical conundrum where we demystified the case. I'm straight away going with the case. He is a 23-year-old case, 23-year-old man. He presented with us with a bilateral pedal edema. He actually presented to a vascular surgeon and bilateral pedal edema. On evaluation, he got a renal failure and he has a proteinuria also. This happened in March 2021. The one history he gives is he has a back pain for which he has taken Ayurvedic medications a few weeks back. And this admission, we diagnosed him as an acute bilateral deep vein thrombosis. And next. And we actually planned for renal biopsy. Following that, anticoagulation we planned, but he wanted a referral by a higher center, and he lost follow-up with us. This happened in a COVID time. So actually, he presented to next slide. He presented to us exactly 1 year later with the uremic symptoms and dialysis dependent stage. And in between, he got a biopsy done elsewhere, and it showed IgA nephropathy, biopsy proven with the industry. And he was treated in MMC for IVC thrombosis with thrombolysis. Followed anticoagulation was given, and there also he was lost follow-up. It was second wave of COVID period, so it was very severe. So he lost follow-up there also, and we initiated him in dialysis in 2022. Follow that, we created an access. Left AV radiocephalic fistula has been created. Next slide. And we on examination his abdomen, he will show bilateral collateral vein formation over both sides of iliac region. The veins are really large veins. We can see it in the pictures. Next slide. Yeah. Both sides, large collateral veins were there over iliac regions. Next slide. And his dialysis vintage, he mostly uses thrice weekly dialysis. Sometimes he requires 4 or 5 times a week dialysis. Frequent complication, frequent admissions will be there for acute pulmonary edema, cramps, hypotension. He will have all the complication. I have seen him with the cramps in his jaw. First time I am seeing jaw muscles, he got a cramps actually. And he was not doing well in a dialysis. Next slide. And before proceeding, we have done a CT venogram of abdomen that was showing both lumbar veins confluence was there up to patent up to right atrium, but there is a completely collapsed bilateral common iliac, external iliac, and internal iliac veins. There is the veins, we can't see it in CT itself. Next picture. Next slide. Yeah, you can see it in a slide where right side of the picture, the aorta bifurcate, and if you see left side, the vein abruptly stop. Abruptly stop. We can't trace the vein below, and there is all the veins in both the side, the common iliac, internal, external, all the things were collapsed. So literally the lower limb veins drain through superficial veins. That veins we can see it in the clinically we can see in the patient over the abdomen where the collateral veins enlarged collateral veins we can see. Next slide. And because we got an IVC thrombosis, we got an hematologist opinion. Hypercoagulable state workup has been done completely, and it was negative. And he was there on dialysis for past 2 years, 3 years down the line. He has done almost 300 cycles of hemodialysis with us. But we never had any issue with the access. Access was completely perfect. He never had any thrombosis or any other complication during vascular issues. He didn't have. Next slide. And since dialysis was very complicated for, we planned for a transplant, and transplant counseling has been given. Mother was willing to donate, and mother was fit. And CT venogram for donor, double artery was there in the left side, and single artery was there in vein, right. So we planned for right open donor nephrectomy. Next slide. Next slide. Then the question comes, where to place the graft? Because in usual iliac region, we can't place because the veins were totally collapsed. We don't have an option, much options. Usual conventional method, we can't go ahead because of extensive bilateral collateral. We can't open it, and the below the veins also not there. It was collapsed. So other options we kept in the mind was portal vein, native renal vein. And we plan to even keep it in a iliac region, and we plan to use an AV access fistula vein as a graft. We can plan as a vein as a graft. This was an idea given by Dr. Vale sir. And we plan to retroperitoneal region also. We plan to connect it to greater vessels. Next slide. And literature search, so many case series has been there. In that, they given a splenic vein is also an option. After splenectomy, we can connect that vein to the splenic vein, ascending lumbar vein, gonadal vein, superior mesenteric vein, inferior mesenteric vein. This all were there in the options. These are mostly we have taken the only few case scenarios and few case reports and case series are there. One of the major case series I took it from a Japan. In Tokyo University, where they done in a pediatric nephrology department, where they have done some 13 cases they have done. Next slide. In the 13 cases, most of the cases where they had an IVC thrombosis. Following that, they have an anastomosis. In the following, the above options, they have placed it. 13 cases they have. Slowly, in the 13 cases, most of them they are placed in the pattern segment of IVC. Most of the cases they kept it in IVC only. Next slide. Next slide. Yeah. Before preparing a surgery, preparation for surgery, we kept a AV fistula hand also prepared in case it's needed for a backup, and we kept an artificial graft ring. PTFE graft and Dacron graft also we have kept it as a backup. And bowel preparation was twice we have done a bowel preparation since we have planned for intraperitoneal approach. And also we kept in mind that if the anastomosis, any viability is not option to proceed with the transplant. So we plan to even to stop and case in between. So first we have opened, we plan to open the recipient, then only to proceed. If viability is there, then only we plan to open the donor. That is the reverse way. Usually we'll do a donor first, then we'll go for recipient. But in this case, we plan to open the recipient first and to see whether the vein is viable for any anastomosis. Then only if viability is there, then we plan to proceed with it. Donor side induction, anesthesia induction. Next slide. And we proceed with the renal transplant on 8/10/2024 with a central vertical insertion, and almost all visceral peritoneum visceral rotation has been made. Lateral branch maneuver that has been followed, and to expose aorta and IVC. And on feasibility of anastomosis before anesthesia. anastomosis. Then we proceeded with induction with the donor. Next. Next slide. Yeah. And we plan to keep the kidney on a right side because it, right lumbar region just below the native kidney, where the in the retroperitoneal space, because anastomosis in the right side will be easy because of vein, the small length itself is sufficient. And we given heparin 2500 units IV before clamping the greater vessels, aorta and IVC, and graft vein anastomosis to IVC 18 minutes, and graft artery was anastomosis to aorta over 21 minutes, and total anastomotic time was 38 minutes. Next slide. Next. Yeah. And most post-op period was uneventful. Given a heparin subcutaneous for 3 days, and I have not started on any oral anticoagulation after that. Now patient is in follow-up with me, 11 month post-transplant. Creatinine is 0.9, and I show the Doppler ultrasound. Next slide. You can see the native kidney. Just below it, we kept a graft kidney so that biopsy is easily possible. So we kept it in a retroperitoneal space, the lumbar region. Next slide. Next slide. Doppler, we can see where the graft vein has been anastomosis to IVC and graft artery with aorta. Next slide. And in a short, he presented with us in March 2021 with the DVT and acute renal vein, acute bilateral DVT. And 2021 July, he presented to MMC where he treated with thrombolysis. Then lost follow-up there. 2021 around December, November, he had a biopsy. The native biopsy, IgA nephropathy was proven. 2022, we started January. We started on dialysis, and 2024 we proceeded with the renal transplant. Now 2025, the creatinine is normal. Next slide. Next video. Can you play video? This is anastomotic time video we have taken. Can you play the video? This is iliac vein occlusion.
Bilateral iliac vein thrombosis. So this is the IVC. This is the aorta. Patient a right donor nephrectomy. Right kidney has been kept here. The vein has been anastomosed to the IVC here. You can see the gonadal vein which is coming and joining. So this below the gonadal vein, we have placed the kidney in the right lumbar region, and this is the renal artery which has been anastomosed to the aorta of the patient, infrarenal aorta of the patient. And you can see good urine output. You can see the urine output. You can see this.
ஆர்டரியோட அதிகமாக யூரின்ல தான் ஃப்ளோ.
Okay. Thank you. Thank you.
This is our team, and the surgery has been done in a Sudha Hospital, Europe. Thank you. Presentation.
Nagendran, excellent. Can you unshare the slide so that we can have a... Okay. So where you got anastomosis is a ureter?
Sir, ureter, we tracked down the native ureter. Same line we have anastomosis. Central, we have anastomosis.
You have anastomosis to the bladder. Native ureter. I mean,
Bladder, native.
So you took some you would have to,
Sorry, sir. May I join? Murli,
please,
sir.
Murli, please.
We anastomose the ureter to the bladder, just like how we do it on a routine basis. It's
Super.
just that the
Okay.
length of the ureter is a little bit longer than what we usually take. But it has followed the natural course, just like how the unascended kidney will be. So the kidney is like, if there is an unrotated, malrotated kidney which is not ascended up, so it will take the same route. The ureter has been kept along the same track, so that it will be easy for, we do not want any anastomosis, and we kept the kidney as low as possible because like we wanted to use the lowest most pattern segment of IVC, so that the ureteric length can be minimized as much as possible, so that we don't get any distal ureteric ischemia or anything.
Oh, that's a great point. Okay. So So okay. So the thing is, the one thing I should appreciate is here you opened the recipient first, witnessed everything is all right, then you went ahead with the donor side. It's a good point. I think we have to, so you use the native, I mean, a graft ureter to anastomosis one, right? That's one other point. I just want to ask one more thing. Okay. So now I ask that, sir, Ramling sir, have you encountered any such case in your practice? Because you have a lengthy time of 4 decades in your practice. Have you encountered this kind of complex case, sir?
No, well, not in adults. In the beginning of 1980s, where we were doing transplant, we had a child with cystinosis,
Okay, sir.
6-year-old male, and there was renal failure. In those days, there was no treatment for cystinosis. One of the treatments was renal transplantation. So we did a transplant at that time, taking the 40-year-old father's kidney. And at that time, we had to use the aorta and the inferior vena cava for anastomosing the father's renal artery and renal vein.
To accommodate the kidney. Okay,
Yeah,
fine, sir.
accommodate the kidney.
Yeah, that's
Apart
right.
from that, we have not had occasion to use the this, but also we had again a child who came to us for transplant while she was about 7-8 years old, and had 3 transplants by the time she was 32-year-old, and came up for the 4th transplant.
Oh.
And the 4th transplant we had to use on the aorta and the vena cava, because there were no arteries on the external common iliac wall. So 4th transplant we did using the aorta and the vena cava. So this is at the time she was 36, 37-year-old. So these are the 2 experiences we have had, and we have not had this extensive thrombosis of the veins. We had just had veins which are exhausted because of use, or which were too small for use. And this is very good. And I think, as you pointed out rightly, they planned well, made sure that they would be able to use the recipient and then open the donor. Very good. Congrats, both of you.
Thank you, sir. Thank you.
Murli?
Thanks a lot, sir. Raj,
Neil, sir?
Yeah.
Shall I ask?
Yeah, please.
Thank you, Murli, for the valiant effort you took and the care. And just to explain us, how do you, can you explain us about the graft artery aorta anastomosis? How long we have to, we can keep the cross clamping, whether you put a partial clamp or can you explain us how you anastomose graft artery with aorta?
Okay, sir. Sir, actually, the anastomosis was done in partial clamping. We put a Satinsky just like how we do for the external iliac artery. We put a Satinsky, but there will be like not big. The artery will not. The aorta will be like will be just enough to accommodate a small aortic punch. So it is otherwise same. The only thing is when you clamp the aorta, what happens is the body's lower limb blood perfusion stops. So that the afterload will suddenly rise. The patient will have, the heart will have to, and will have to take in the afterload rise. But this usually happens when there is a normal circulation is happening there, and suddenly when you stop it, it can be dilapidating, and that it can cause ischemia to the pelvis, ischemia to the limbs. And when you open the clamp, patient can have a ischemia reperfusion injury that can cause BP drop. But we have primed the anesthetist saying that this is what the plan is. So they were all ready for like reperfusing and ensuring that the BP stays stable postoperatively. But we were actually, touch wood, we were lucky enough to have a good space in the aorta. We are lucky enough to get a good clamp position in. And just, I think like everything went with as Sarah's already pointed out, we did a lot of planning. In fact, I think when Nagendran told me about this case around 3-4 months before, and like we were trying initially, like getting used to that place. Initially, I have not operated on that hospital before, so I want to do a couple of transplant to see if the anastomosis, if the team is all okay. And then we did straightforward cases, when we did some difficult cases, and then only we went on to do this case. So I think like Nagendran did a lot of job, and to maintain the patient, it was also the patient was very well primed in the sense like he had a good dialysis. He was very dry. There was no there. In fact, the veins to see on the photo did not show the true picture of the veins. The veins were like huge, very, very huge. Some of the veins, if you could get the picture, if you get to see the CT scan, the veins are almost around the size of IVC. So whenever we injure these veins, they just profusely bleed, and the venous bleed is very tremendous. So there was like we wanted to ensure that we do not cause any harm to the donor, just as Sarah's already pointed out. Before we do anything, we don't want to cause any harm. We wanted to ensure that we were stable and we had a good space and we could execute the plan. Only when we were sure, I think like we took a break and then we came back and did once the kidney was benched, we came back, it was scrubbed up, and then we came back in and then did the procedure.
Thank you, Murali. Dr. Nagendran, just a small question. Thank you for this presentation. What is the cause of DVT? Have you ever worked for the hypercoagulation?
COVID related.
It was in the period of first and second COVID period he presented to us. Actually, it was a peak COVID time. I don't know whether it's due to COVID or not, but his native biopsy was showing IgA nephropathy. But we had done complete hypercoagulable workup, protein C, protein S, APLA, all the things we have done. It came negative. And one thing I noted is, whenever we are doing hemodialysis for almost 2.5 years, he has been with hemodialysis with us. Since not even single episode of thrombotic episodes we faced. That's why I'm very confident. Other question also they have asked, why not anticoagulation? I'm very sure he is not going to have, if the anastomosis is perfect and it is going to stay 1 or 2 days, if its graft is going to survive, then I don't think so anticoagulation is not required, because I think that why he developed that bilateral DVT and IVC thrombus, I don't know. The cause we don't know, sir. But I'm sure he is not having any hypercoagulable state, because if Spisla was so much, still know it is functioning. He never had any thrombotic issue during dialysis. That one episode, how he got, we don't know. He is saying some. He gone for some massage center actually for his back pain. He told me actually given some severe compression was given in the back. I don't know whether traumatic it can be. I don't know, sir. That cause we don't know, sir.
Was he on IVC filter? Actually, he was.
No, sir. No. He was not on IVC filter.
Thrombosis. Okay, probably. One quick question to Murali can answer that. So after the transplant, what is the collaterals like, Nagendran? What is it subsiding or is it same?
No, sir. It's same actually. The one picture I have taken last week.
So he's completely comfortable with the collaterals, right? Lower limb is
his lower limb pain. Lower limb is suffering because of collaterals only. That's why we don't want to disturb it. That's why we went with the central midline.
Fine. You respected the nature.
Just to add a point, whenever there is a IVC thrombosis, the collaterals will be there in the parietal wall. It will be never there in the intraviscera or midline. So midline is a relatively bloodless field. And we are not treating the lower limb DVT. So if we cut the collateral veins, patient will again go back to the old picture. So we really wanted to preserve those veins. The CT actually, the radiologist also gave a lot of help. We actually pestered them with a lot of questions regarding the diameters and the stuff. And they were very helpful, because we wanted to visualize the delayed venous phase. We wanted to see where the collaterals are, whether we would inquire, because we are going to do a retroperitonealization. We are going to mobilize the bubble to the midline, cattle brush maneuver. We wanted to know whether there will be any collaterals, paravisceral collateral which are there, but luckily they were not there. Usually they are not there. Even when we do bypasses for DVT, some cases where iliocaval bypasses when we do, they also do not have any collaterals there, but sometimes they can have. Very rarely they do have abnormal collaterals. I think that was seen. You should not cut those
collateral
collaterals.
veins are very large diameters. It was very huge veins actually.
That is a lifeline for the patients to for venous return.
Sir,
So,
I think like
Mahendra,
some of
yeah, where
the
exactly
questions in
that,
chat box, if I could answer that. Ganesh sir has already asked, like, given the non-visualization of the lower limb branches of vein, should we give the long anticoagulation in the long run? So the idea principle, I mean, what we followed was like it is an acute provoked DVT. Usually the provoked episode of DVT, we give anticoagulation for around 3 months and we stop. We do not give anticoagulation on a longer period of time. So we just followed the same principle here because this patient, we mobilized him early in the initial phase. We kept him on DVT prophylaxis and then we did not stop it. And I think like anticoagulation is like we do not want to have any bleeding diathesis or anything in the future which cause a compromise. So that's why we didn't put, but we did give DVT prophylaxis. He did have DVT stockings. He did have apparent in the initial postoperative period. And Dr. Arun has asked about like the time. I think we started at around 5 o'clock in the
5 o'clock
morning, and the 9 o'clock we had a breakfast.
9
9
o'clock
o'clock we came for the breakfast.
Yeah.
that's great, man. Great. That shows your work. Okay. So one thing, Nagendran, where exactly the thrombus starts in the femoral vein or the iliac veins? What is the intake? You mean to say that the entire lower limb veins are thrombosed?
Yes, sir.
Yes,
It is the iliac
lower limb
vein,
veins are
femoral
not sick.
segment, everything is thrombosed.
From popliteal
Everything
to
was-
femoral to
Yes.
iliac to everything.
Everything was thrombosed.
Oh,
His
Nothing
GSV
was
was dilated, his abdominal veins were dilated, his like suprapubic veins were dilated.
okay.
All the veins was dilated, sir. All superficial veins were dilated.
See, you have done a marvelous work, and his patient is doing well. Credit is 1.1. See, if suppose one hypothetical scenario, suppose the donor side, if they cut the ureter very short, then what was your idea to go ahead with?
I've asked you previously also. We planned to anastomose to the native opposite ureter or same side ureter. We are planning to keep it in that ureter. Actually, native ureter we plan to anastomose.
Tell you one very important point. In a long-standing anuric patients, or maybe around 1 year, 2 years anuric patients, if you want to really anastomose for any given situation, native graft ureter to the native ureter, please make sure that the ureters are intact. 30 to 40% of the time, ureters are atretic. When the patient goes for an anuria, the ureter will go for it. We got stuck in one situation where we went inside. We could not anastomose on the native ureter because the native was totally like cord-like one. So if you have a plan of to the audience, any people here who are doing the high volume of transplant work, if you want to really envisage that you are going to do anastomose with the graft ureter, the native ureter, we have to assess the patency of the ureter by scopy or something like that, or you can put a stent to identify early. This is one just hypothetical question I asked, but you planned very meticulously. So you did a recipient surgery first, then make sure everything is all right. You didn't harm that donor. Then you went ahead deep down to the ureter. You took the ureter length. So that's what everything went in a very as you planned. Great work, Murali. You want to add anything more from vascular point of view?
Sir, from vascular point of view?
Anything you want to add more? Anything like that? What are the
I think everything has been covered. So just that if there is, we should not rule out the option of doing the kidney transplant to in the aorta or IVC, even if the patient is going to have a DVT or like iliocaval occlusion. I think this should not be like we should have this in the back of the mind so that we can really do it. It's a patient. It was totally uneventful procedure. Just a little. It needed planning. It needed a lot of planning, and I think it can be done. I think it is just to it's not just to show the world that we have done it. It's just to tell the world that even if the patient has something, I think we should not deny a transplant for this cause. And this should be done for them.
Okay,
Sir, there was a question in the chat box by Dr. Remy Thomas. They were asking about bowel loading and kinking of vein. Is it possible? The kidney is placed in the retroperitoneum and the bowel is placed back. So the bowel has come back to its original position. The kidney is totally retroperitoneal. And this is one reason why we did this, because like if the patient is developing a complication and if we need to do a biopsy, it should be like accessible. If we keep the kidney in the intraperitoneal space, it's very difficult to get the biopsy done. So that is the reason why we kept the kidney just below the native kidney. And one of the option which was kept in like Nagendran has already mentioned is like anastomosing to the native renal, left-right renal. We were wondering whether we can do a right nephrectomy and keep the kidney there. Just like an auto transplantation, take this kidney out and keep that kidney there so that it will be amenable for biopsy and follow up and everything. So kinking is not an issue at all. Kinking is like it's a straightforward rate of internalization. There will be no visceroptosis, and the bowel will take care of it. And the second thing is bowel, it cannot compress on it, and because bowel has already, there will not be any herniation because whatever the bowel has been mobilized had been placed back just like how it was before, and then we sutured the abdomen.
That's another one point, sir. The main the options I have taken from the one Japanese case series where they have done 13 cases. All of them, as Ramalingam sir pointed out, most of the all the cases has been pediatric cases where the artery anastomosis has been done to the aorta. And other options they have tried. Mostly they have around out of 13 cases, 7 cases or 8 cases they have used a graft, artificial graft. Mostly in that 7 or 8 cases, they have failed in 6 attempts actually. The graft life has not survived more than 3 or 4 months maximum. So if possible, preferably to use a native vein. So any options of taking in native veins is there, we can we should use rather than using an artificial graft, because most of the failures for them has been found in the graft. Last 3 or 4 cases, they have 5 cases they have seen they have had succeeded. All they have used a native veins. Ovarian vein they have used, clinic vein they have used, different option they have taken actually. That
Actually, this
surgical
patient, Dr. Shakti has also asked the question about like why not use the gonadal vein. I think we had a good IVC by the side. If that was not an option, gonadal vein we would have resorted. But since the IVC was there, we just resorted to IVC. Otherwise, if not, I think gonadal vein could be used as well. But because of the side, IVC was good enough there, we just choose the better vein there.
Okay, it's all on table decision after all, right? Once you open, what's the options available. Only thing you have to see to it that the anatomy, location, post care, biopsy, feasibility, everything. I think we have succeeded. The final one question to you, then we'll wind up. So, what was the BMI of the patient? If the patient is very obese, 45.
donor recipient is very
recipient. BMI. He's
recipient
very lean
is
fellow,
lean
right?
lean fellow. He is very lean. He is lean. Now he added weight actually.
So had it been a very obese patient, what was your surgical risk? I mean, the time and everything. So probably it may take different course, right, Murli?
True, sir. Very true. But I think like if considering the same scenario, veins should not be a problem. It's just that probably somebody has asked how much time it took. Maybe we may have come for we may have had the breakfast and then come back for lunch for a different, because we would have taken some little bit more time to ensure that bowel rotation and other things. So because of it was a lean patient, we were able to do it in a quite a good time. Probably if it is an obese patient, we would have taken a little bit more time to do it. But I think it's not impossible. It's certainly possible. It should always be kept in the back of the mind in the worst case scenario.
Thanks, Murli. Thanks for everything. And you are.
Thanks a lot, sir. Thank you, sir.
And I think you have become ISOT member, so to contribute us more, right?
Probably, sir. I'll certainly try and meet everyone during the ISOT
thanks
conference.
a lot for bringing this case. At least some people might have encountered this phenomenon. We cannot say no to anybody, because as this patient was, literally was looking for a good kind of RRT, transplant was the best solution for him. We offered. I think patient is doing well. This is the best learning point for every one of us. Thanks, Murli. Thank you.
Thank you,
So
sir. Thank you,
move
sir.
on to Dr. Ilangan Veerappan. I think we have 25 minutes for him to talk, and he's going to talk very, same topic with a different angle, and his perspective will be entirely different. Looking forward to listening to Ilangan. Please go ahead share your slide and start your presentation. Yeah, make it play mode and you can start, Ilangan.
Yeah, first of all, I think congrats to to Dr. Nagendran and Dr. Murli. I think fantastic planning more than anything. No execution, of course, is very difficult. I think you guys did a brilliant planning, and I like the first part. You ensured that I think Murli was operating on this hospital for the first time, so you ensured that he was comfortable, and even that kind of planning they did before the execution. No, I think brilliant it is.
Yeah, great.
And they also had plan B, plan C also, so brilliant. So this today's presentation, I'll try to keep as brief as possible, because many of the points what I'm going to discuss is something that we a lot of times face, but then like we don't dwell too much on it. So these are basically my reflections of what publications has been done on these areas, both in India. I've been all my slides are mostly on Indian data. I've been very careful in choosing mostly Indian data and very little outside India. So first of all, like what is the scheme of today's presentation? So I'm not going to talk on all aspects of kidney allograft rejection prevention and early detections. I kept myself to the ones which is easily available to all of us who are listening today's presentation. So first is pre-transplant planning. I'm going to talk only on HLA matching, especially eplet matching. Now then, in Ramling & Sir's unit, they have a brilliant molecular diagnostic lab, and that is very much feasible. So, and how eplet matching and mismatching can help us to identify patients who are really at high risk versus low risk. Then my experience with desensitization. We know that every center has its own desensitization protocol. So my current desensitization protocol. Then in the immediate transplant period, especially peri-transplant period, how to individualize induction immunosuppression. This is basically completely my opinion based on what is published from in India. So I'm not going to talk on anything that is published outside India. So only on Indian publication. And post-transplant, how do we individualize maintenance immunosuppression? As nephrologists, this is also an important area. And do we need to do a DSA monitoring? And do we need to do a protocol biopsy? So that's all I'm going to talk, nothing more. So eplet mismatches. So these two are real patients, case 1, case 2. Both of them are spousal transplants, spousal donors. They are in that in the phase of evaluation. We are yet to do transplant for this. And both of them have similar mismatches. They roughly have around 1 to 2 around 10 out of 12, 11 out of 12 mismatches each. So on superficial appearance, it appears like a spousal transplant. You have like close to 10 out of 12 mismatches. They appear similar. But what is not similar is when you do eplet mismatch analysis for this. I've done this. I've taken help from Dr. Anil. And what we find is the total number of mismatches are huge. Like as you can see here, like you have total mismatch. You have to add this 32. Total eplet mismatches are like more than 32. And then here you have class 1, class 2 is also high. And here the other one, which is almost similar, is HLA mismatch. But then when you count the eplet mismatches, a lot lesser. And one thing that we all have to understand is among the HLA mismatches, we many times even like I used to like not think too much about the DQ mismatches. But then when it comes to de novo DSA, DQ mismatches are the number 1 antigen. And in this particular case, we have 11 critical DQ mismatch at the eplet level, eplet DQ mismatch. And that puts the patient at extraordinarily high risk of delayed ABMRs, even if we are successful in preventing the initial first 3 months of ABMR by intense immunosuppression. As against the second case where as you can see, there is 0 DQ mismatch and there is only 1 high risk epilepsy. So that this brings us to one more problem. Like not all eplet mismatches are made equal. Some of them are clinically insignificant. Some of them nobody knows is significant or not, and some of them are at high risk of causing de novo DSA. So there is inequality in these mismatches. So why it's important is because when you have an enhanced or a high eplet mismatch, with a very high risk category, like too much of DQ mismatches, you need to consider enhanced immunosuppression protocols. You have to do frequent DSA monitoring, and you need to have early intervention for subclinical rejections, like even having a protocol biopsy early on. And then in the first case where we saw there are 11 DQ eplet mismatches, and they have an extremely high risk of de novo DSA formation. So eplet mismatching analysis will help us to predict which patient needs heightened surveillance, and then like there are published multiple studies have shown that if you have more than 30 total eplet mismatches, out of that more than 19 class 2, then you fall under one of the highest risk categories. And DQ mismatches is more worse for in the delayed DSA positivity, DR more than DR and more than DP and more than ABC. So DQ mismatches are something that are very essential when you are considering long-term graft outcomes. So this is something like many of us, at least I was under the impression, I knew that DQ mismatches are important, especially for when you're considering second transplant. But if you want to consider heightened surveillance, DQ mismatch, especially at eplet level, is very important. So that's one of the learnings we all have to do. And so eplet mismatching is the way forward, and it is available. Dr. Anil from Ramlingam sir's lab can make this happen. And it's an evolving field, and we don't have access to all the gadgets, all the softwares, but whatever we have, we can do it. So this basically, I built it using the published database, available softwares, and with the help of Dr. Anil, we were able to identify that these were the critical mismatches. Okay, so, and this is again to drive home the point that not all eplet mismatches are important, and not all form de novo DSA. So this is a pediatric transplant population. You can see here that this is arranged in prevalence of eplet mismatches in that population. And you can see here the highest number of eplet mismatches do not transform into high amount of de novo DSA. There are some DSA eplet mismatches which are more critical, like as you can see here, the one that is not very commonly found in the population, the total number of mismatches, but they are more likely to form de novo DSA. So we need to also understand that only some of the mismatches are really clinically relevant, and only some of them really cause. So the most common mismatch eplet were not the most likely to cause de novo DSA, only some of them cause. And again, when it comes to HLA DQ eplet mismatch, there is with increasing dose of eplet mismatches at DQ level, you have more heightened risk of de novo DSA. So this has been shown beautifully in one of these recent papers. So we have to concentrate on DQ mismatches, especially if you want to think about long-term graft surveillance and long-term graft outcomes. So I'll quickly skip this because it's going to reiterate the same this. So eplet mismatches will identify patients who will need focused surveillance. So this is number one learning today. And I've been using daratumumab, which is anti-CD38 for desensitization, because so and daratumumab is past phase 1, phase 2 trials, and they have been used now more commonly in myeloma patients. And they act also on the same plasma cells like the bortezomib, but their mechanism of action is different. And it's been shown that there is no major side effects except the infusion reaction, and there is a very significant decrease in anti-HLA antibodies observed in the short term. However, like in a 1 year of follow-up, they do return back to previous levels. But however, it makes transplant feasible, and I'll share some 3 patients where we used. The first 2 patients had a very low MO5. All of them had a negative CDC and flow cross match. And so in the center where we share the immunology lab, what Dr. Ramlingam sir has built. So the MFI values around 2,500 plus usually gets picked up by the flow cross match. But in this case, I really don't know why it didn't pick it up. But here what happened was the 2,900, 2,700 in 2 weeks time became less than 2,000. And this patient had a 12,900, it became 1,400. So we did not do plasmapheresis, we did not do any other desensitization other than daratumumab, and we were able to desensitize especially the third one. We are a little worried. And it was a anti-DR antibody, quite quite significant one. And so, but we are able to do, and we gave ATG for all these people. Only the first patient who was a second transplant had an ACR, I3T3, and we know, like, whenever we use anti-B cell therapies, ACRs are slightly more commoner than otherwise. So we were like, after the first case, I was thinking maybe the next two also we would have ACRs, but we did a protocol biopsy for the first two patients. And the third one we did not do, as that patient has just completed 1 month and entered the second month, and we would want to do it and see. So daratumumab is one more agent in our armamentarium, and they seem to be having no major short-term side effect, at least. So it makes life easier when it comes to desensitization in the short term. So next is which induction agent to use and how to use. So this is a problem, like, it's been going on for a long time, and the data is not very clear. So what I did was I collected all the data published in India and then collated that into one, like ATG versus ATLG. So why should we fight over which to use? So I'll give you a situation where we can use both. I mean, both in the same, not in the same patient, in a same transplant unit. So if you see here, these are all published data from India. So these are all not Western data. These are all Indian data. So the inflection point for a ATG is roughly around 3. So if you see, like, if you give 3 milligram per kg body weight of ATG, you see that the infection risk and the rejection risk are like, if you use as a combination, it's at the lowest possible. The moment you give a higher dose, 4 or 5 or 6, you can see that the red bars or the rejection risk keeps coming down. But then, like, there's a trade-off with increased risk of infection risk, and also increased, of course, they would come with increased mortality also. So 3 milligrams seems to be a good inflection point. So this is purely based on published data from India, and then, like, and these are all done in the last 5 years. So these are all, like, carefully selected only in the last 5 years, because, like, what was done 10 years, 20 years back, the infection rates were different. So the outcomes were slightly different. So it may not be applicable in this decade. So I carefully selected. So this is a learning we have. So if your center has very low infection, probably you can go beyond 3. And if you're struggling with more infection, probably you have to think twice. So this is what the Indian data shows. And likewise for the ATLG. So I'm not going to talk on basiliximab. So ATLG, if you can see here, the rejection risk keeps coming down with increasing dose, like what we see in the ATG. But surprisingly, if you see the infection risk does not change much. So if anybody has to use ATLG, you probably have to use a dose more than 6 to have a significantly reduced rejection risk. And so you should see here, the y-axis is different for both this. So here, if you see 0s, 2, 4, 6, and here it's 0, 5, 10. So you don't get misled. The rejection rates are slightly higher on Graflon as against ATG. But then, like, the difference is becoming narrower and narrower, especially when you use a dose of 2.5 3 milligram for ATG as against 6 milligram for ATLG. The difference between these two agents when it comes to rejection risk is small. But the infection rates are infection rates are definitely lesser. They're lesser with Graflon, even at higher doses. So again, if you have a patient who has a lower risk of rejections and lower risk of de novo DSA, but then you're worried about infection risk, you can choose a Graflon. But then, like, if you are worried about immunological problems and infections you feel that you can manage, then I think you should use ATG. So this is my take on these two. Again, like, there is no studies to prove beyond what I'm saying. Like, but then why should we worry about using either of one of the two? We can use both in a unit in a case-to-case basis. And coming to individualizing maintenance immunosuppression, so I would first talk on mycophenolate, Mofetil. So I think time has come where, like, if you want to improve your transplant outcomes, you need to strongly consider doing MPA-AUC. I know, like, many of the senior, especially the senior nephrologists, they really don't need this test because their brain works like a computer. They really know who would at more risk. They're more often right. In fact, they would be like 90% as good as a artificial intelligence enabled younger nephrologist, but then they are as good. I feel their brain works like a computer. But then, like, this is my opinion on mycophenolate AUC. Like, if you have to improve your outcomes, you need to do this. 40 is the magic number. So at 40, what happens is if you have a MPA AUC of 40 milligram hour per liter, the risk of rejection is lowest, and also the risk of infection also is acceptably low. And beyond 60, the infection rates increase, and below 30, the rejection rates increases. And this has been shown both by studies outside the country and also by CMC Vellore cohort. So measuring mycophenolate AUC gives you that little extra. So a lot of our centers have very good results even without this. But then, like, you want to improve your outcomes by 2%, 3% better than what you're doing. So this is one we have to do. And this is our center data. So here we see here, like, you can see the blue colored shadow one is 30 to 60 marks. So that's the area where you get less infections and less rejections. So I would like to point out, recently we had one patient who was transferred from another unit from Delhi to here, and patient had a late ACR, that she had diarrhea. So the doctor switched from MMF to Azoran, but after the switch for the next 1.5 to 2 years, gradually she's having creeping creatinine, and a biopsy later showed significant IPTA. So, like, in patients who are higher immunological risk, especially people who have normal TAC level, but then the normal range of TAC level, and then but still having ACR. So switching from Azoran to MMF is not a great idea always. So now what normally I do is I switch to either Azoran or everolimus for a short period till the diarrhea settles, and again I put them back on MMF. I don't let them be on Azoran, especially if they fall in the high immunological risk category. If they're low risk category, no problems. I leave them on azothioprine, but otherwise, I put them back on mycophenolate. So what I did was, this patient, when by the time she saw me, it was 2.8. And another important thing she had was, at the end of 3 to 4 weeks, so one of the doctor was putting the patient back on lower dose of Azoran. So what people tend to forget is, when your creatinine keeps increasing, the metabolites of Azoran, the half-life increases. So it takes roughly around 4 to 6 weeks for all the metabolites of Azoran to really come to a very low level, myelosuppression to disappear. So the patient, out of fear that kidney may reject, she was taking intermittently Azoran also. And then it was causing severe bone marrow suppression, recurrent pneumonias, recurrent readmission in the hospital, because people were not willing to let go of Azoran. At the same time, they're scared to put the patient back on mycophenolate. So what I did was, I just stopped the patient on Azoran, waited for a month, put her back on MMF, and she's doing really well now. She's gaining weight, no infections, no pancytopenia, the kidney function is improving. And so mycophenolate, we should learn to use it, and we should also be very much aware of the drug levels, especially Azoran causes toxicity in renal failure, and nephrologists should be knowing. So that is what the patient was struggling because of that particular information. So now coming to tacrolimus. So we know that for stable creatinine, we need to keep it around 5 to 8, even in the long term. And in patients with even more lower risk, maybe we can bring it down to 4 to 7. So we cannot keep it very low levels, because if you keep it, I've seen patients even beyond 20 years, 25 years. If you take them off on CNIs, they can have DNO, DSAs and cause late rejection. So many of the patients may escape, but there are a bunch of patients who get caught with de novo DSA even beyond 15, 20 years of transplant. So this is a very important bunch of slides I'm going to say, like tacrolimus variability due to drug-to-drug interactions. So there are more than 300 significant interactions we all have to be aware of, but I'm going to talk only on one interaction today. That is like role of proton pump inhibitors in tacrolimus metabolism. So for the first one, if you see here, this is baseline. Okay, so this one is on tacrolimus AUC, not on C0. And if you use famotidine, there is absolutely no effect, no change. So in our unit, but the default anti-ulcer agent we use is famotidine or ranitidine. And the moment you give omeprazole, you can see there is like 16% increase in AUC. Again, when it comes to peak concentration, the same thing happens here. The C2, the omeprazole, there is 26% increase. And if you add, we know that omeprazole has CYP2C19 genotype can affect. And in fact, if you give omeprazole to people taking clopidogrel, and if they have a very, what to say, this particular genotype, the patient can even have a stent thrombosis. So omeprazole giving to patient with taking clopidogrel, and if they have this mutation, you can lose. And this mutation is quite common in our population, South Indian Tamil population. So in patients who are extensive poor metabolizer of omeprazole, not tacrolimus, the TAC level can increase even like from, this is all nanogram per ml per milligram of tacrolimus, from 2 to 6, like almost 3 times the drug levels can increase. So rabeprazole is safer, famotidine is better. So rabeprazole, pantoprazole have minimal interaction with tacrolimus, but lansoprazole, omeprazole, esomeprazole all have very high interactions and they can increase. So why this is important is when you are doing therapeutic drug monitoring, tacrolimus C0s we are monitoring, and if the patient is intermittently taking these levels, and especially this effect is more pronounced in patients who are all very extensive metabolizer or poor metabolizer. So this effect is exaggerated in patients who are poor metabolizers for tacrolimus as against people who are extensive metabolizers. So if you have a patient who's poor metabolizer and he's under the influence of proton pump inhibitors, the drug levels can vary anywhere between like 7 to 20. So when you stop pantoprazole, when you stop the proton pump inhibitor, the drug level again will crash, and the patient will have a huge C0 variability, and you can have problems. So why this is important is, so, and also we should be aware that Indian population is likely different from the Western population. We have more slow metabolizers, more rapid metabolizers in our cohort, more than the Western population. And then, like if you see here, tacrolimus C0 variability, it affects graft outcomes, especially in patients who have high immunological group. So you have to see the chart like this. So then the high immunological group, if you can see the high degree of tacrolimus variability can have such adverse graft outcomes as against low. So this variability will not affect one group of patients, but when a patient has high immunological group, they get affected. And similarly, if you see the cumulative probability of long-term ABMR, again, if you see in the high immunological risk group, the variability is very high. And we need to know everything that affects the C0 or tacrolimus variability. It is extremely important to be a very good nephrologist and you should know at each and every interactions. Like for example, even drugs like Norflox can affect a small group of patients, especially if they are slow metabolizers of tacrolimus. But then the other levoflox, tacrolimus, Norflox increases TAC level, and if the patient taking these drugs and they come with a TAC level, we'll reduce it, and next week the track will crash. So we should be completely aware of all the interactions. And this is a very beautiful meta-analysis. I've made it into a bubble plot. I like bubble plots, so it gives more graphic So you can see here when the variability is more than 30% of C0, and you can see more than 30%. So this is a 30% mark. And if you see more, you can see the yellow or red ones are bad outcomes. You have low 5-year graft survival. And as against when the variability is lower than 30%, then you have a better long-term graft survival. So this is for across all patients, across all risks category. And this effect is exaggerated in patients with high risk. So I have few patients who have had late ABMRs, the only reason being very wide tacrolimus variability. So I used to wonder if these fellows never had such wide variability, because they used to have intermittent diarrhea and it used to be a big headache in managing these TAC levels. And these people tend to have late ABMRs. Despite all what you do, this variability can take the graft life out of these patients. So how do we do DSA monitoring for the allograft? That's the next one we are going to see. So it's very difficult because of the cost. We all know monitoring DSA is in an ideal world very good, but then very difficult. So which group will you want to do? Because this is the grade of evidence. You can see here a lot of 1A, 1C and all is there. So they are very good in preventing ABMRs, but then cost is a big issue. So one way of looking at this is like I used to intermittently do because of the cost. I don't do like in people who are PRA negative. We know like most of the patients are PRA negative. So if they are PRA negative, they come in the lower risk, and you can and then you can monitor them at less frequent intervals, especially if there are not much epileptic mismatches. So you need to categorize them into high immunological risk, low immunological risk, more scientifically, not just looking at HLA mismatches alone. Epileptic mismatches, PRA negative, they're able to afford, and you can do it more frequently. Say, for example, like 1 month, 6 months, like 1 year, like 1.5 years, something like that. So in patients who are resource constrained, but again, they fall into low risk category, then at least once in 6 months we can do. And what is recommended is 3 to 6 months or more frequent in high risk situations. Like if you have a patient who is into high risk, you are supposed to do, but then it's impossible in most centers. Most of the patients cannot afford such frequent monitoring. So you can reduce frequencies in people who are not very, very affordable. But then like if you are just your patients having PRA negative, then I think it's an ideal situation where you can, it's a low cost test. PRA is a low cost test, and the concordance between SAB and PRA is almost more than 95. So it's doable. And so if you do a DSA, it is possible that we will be saving much more grafts in the long term. I mean, at least in the 5-year mark where we have calculated using our Indian data. So we will be able to save some more grafts if you're able to do DSA. For DSA monitoring, 3 to 6 monthly is what we're supposed to do. So you'll be able to pick up cases who are going in the wrong track, treat them early, identify them early, and optimize the immunosuppression, and you will be able to save a lot more grafts, many more years you can give into these patients. And final part of today's presentation, how do you do protocol kidney biopsy? We all know protocol kidney biopsy is good. Many of us would have started and even discontinued. The reason many of us would have discontinued is because many of our transplants we do are lower risk. And in low risk transplant, the benefit of doing a protocol biopsy is almost close to zero, because most of your biopsies will come as normal. The real benefit comes only in patients who really fall into the high risk category. So how do you know? Because we know that you need a lot of knowledge, a lot of data points to know really if somebody is a real high risk. Because I used to struggle very much to categorize them into high risk versus low risk. For me, everybody is one risk. And then, so it's very, very difficult. But then you can have your own, you can audit your own data set. And why I'm saying audit, because unless you audit your own performance, you don't know where you're going right, where you're going wrong. And this is the single most important message in today's presentation. Auditing your own performance is the best method of standardizing your center and benchmarking it against any other center which is considered real standard. So you can have any amount of high risk categorization, and then categorize them into high and low risk. And it's only the high risk patient who need frequent biopsies. So you have to do like first week, second week, first 2 weeks you have to do, then again first month, third month, 6th month, 1 year. So this is on the high risk categories. Whereas in the low risk, you can just skip everything and do one at 6 months, and then one at 1 year, and another one at 2 or more. So that way, like you need not unnecessarily do wasted biopsies in these people, but for higher risk, you have to do more frequently. So that way, what happens is your biopsies will be done more often in patients who really need one. And if you add one more layer of, say, DSA, and then like that will again guide you better when to and not to. So thank you all for your patient listening. And so a lot more can be done by all of us with the existing technology. We really don't need iBox or any of those technologies which have failed. Most of them have failed validation. And I think we should be able to learn to use our own existing technologies much more better, and fill the existing gaps in the data that is published. Because one of the main problem is we are looking for data and these data are missing. So we need to know how to live with absent data, how to fill the absence of data, and then learn to survive in that particular space. I think that is when we need not always look for more data. So we should be happy with whatever data we have and make sense of the existing data. Thank you.
Thanks, Ilangovan. And I think with 25 minutes, you have covered the entire thing. The art of transplant is lies in the orchestrating the post-transplant immunosuppression therapy. You have elucidated in a very nice way. And I think we are overshooting the time. Anyway, we will have it because we will have 10 more minutes discussion. Ramlingam sir, first comment from your side, sir. Then we'll take up every chat box questions and.
Hello.
Yes, sir. Please go ahead, sir.
Thank you. I think I must congratulate Ilangovan, but without wasting time.
Yes, sir.
Ilangovan has rightly pointed out the importance of the epaulette matching, and then he also has pointed out the very great importance of the fact that it is better to do the AUC for the mycophenolate. About 15 years back, we were trying to do it, and that was done only in the CMC hospital, Vellore, and it is a little difficult, but definitely it has its own large advantage. And the fact about the tacrolimus levels modified by many drugs is also very important. And I appreciate him very much for pointing out that the pre-transplant planning with a good histocompatibility laboratory helps a lot. Only thing I am not able to agree with him or have not done is the regular monitoring of the DSA. This we have not done, and at the same time, when we did it in some patients who had sort of rejections proven by the biopsy, antibody-mediated rejections, we did not see it to be present. And and also it's an extremely costly test. And these are the observations I have. And again, I congratulate him.
I think we can have a discussion on every slide you gave some information. One thing, what is the daratumumab cost, Ilangovan?
55 is MRP, sir. I think around 55 is MRP, 400 milligrams.
Okay. You started off with your presentation in from antigenic mismatch to epaulette mismatch, importance of DQ, and your usage of daratumumab and attack variability, utility of MPA or AUC level, and what are the drugs causing attack variability. All are amazing slides. And you just given reinforce our ideas and the utility of azuran versus mycophenolate methylation and the shortcomings of azuran in certain situations. Everything you highlighted so well. And I think you talked from your experience, totally from experience, you put into real perspective, and you were given a new kind of rekindle our ideas to look into our own data, to audit ourselves, to make it as a benchmark against which you can develop your own protocols. Very amazing talk. And I think we'll invite some of the questions from our people who are here and chat box something.
One thing, we have just switched over to high resolution typing for most of our patients, almost definitely for our second transplants or sensitized patients, so that the epileptic matching can be calculated only then.
When you showed two cases, mismatch. You showed only the antigenic mismatch. You didn't talk about the eplet mismatch. So have you looked into it? And that
No, those two cases are eplet mismatches, sir.
Epileptic.
Those are like 52. There are 32 plus eplet mismatches, and that 11 were DQ mismatches, DQ eplet mismatches.
okay. I think every slide you explained. That's why there will be no further questions required. You took a lot of time to explain everything. One thing, I suppose if you do allele typing and a multiple field typing, will your center will help us finding epileptic mismatches? So if the results are done somewhere, if we send it to you, can you do it for? I mean, the center Anil will be able to do it for us.
It may be a little difficult actually, because I interact with him fairly frequently.
Okay.
So it will be it can sometime possible, sometime not possible. So I can check and get back to you, sir.
Okay, it's a very interesting thing. Will you do epileptic mismatch in all patients?
No, because like Dr. Anil is actually not very happy to give it, because the best software is not available. And secondly, the epileptic mismatches, we need to also add one more layer. Actually, what I've showed you is not what Anil gave. I've added one more layer. So what happened is, out of all the epileptic mismatches, which is possible, only around, I think, around 80 are really clinically important. And so I've added that layer, which even I don't know whether Dr. Anil would do that. So I've added that layer and I've highlighted that in today's presentation.
Yeah, very precisely you said that. So most of the may not be in de novo. Yes, sir.
When Anil works with us in
Yes,
the
sir.
molecular diagnostic laboratory we have organized, he is the one who has organized and he is the head. And whenever we get a problem and tell him that we are worried about it, and he goes to eplet mismatching, and he has a set of the mismatches in epilepsy which are clinically relevant, as pointed out rightly by Ilangovan. Lot of mismatches are not clinically relevant, and there are data, and the one software he uses is Matchmaker, and using this he can calculate the total epilepsy in the donor, total epilepsy in the recipient, compare them, and whatever is not comparable, whether they are relevant or not, he is able to find out.
Completion verified. Okay, sir. Fine. Fine. Somebody asked Ilovan in the chat box where the AUC, microfilaric acid AUC has been done. One thing. Second, if a flow was positive, would you have attempted subjecting recipient to undergo transplant?
So I will answer the second one first. So I would want to see if if the patient cannot come with an alternate donor, or patient has failed against multiple donors. In those extremely rare cases, I will see what's the probability they'll get a future match. So if the probability of getting a future better donor than the current donor is low, then I would want, that is when I will do desensitize. And if flow is positive and trying to desensitize is a risky problem, risky proposition. And you should be aware, like some labs do give false positive flow and some labs give false negative flows. So you cannot go by what happened one, because many labs, I mean, not many, at least many of the labs I worked with, I had issues with the flow. So you need to be very sure with the lab you're working with, and with Ramlingam sir's lab gives a flow positive for B, it means you're going to be in trouble. So in that case, you should be ready with all the problems you're going to face to do the real desensitization. So in this case, like I would have actually proceeded even if B cell was B If only the B flow was positive, I would have proceeded with desensitization, because the patient did not have an alternate donor, and they were like very clear that they wanted, and this patient had for logistic reason wanted to proceed. So they could have actually changed, but then they were unwilling to change, and I was ready to do whatever happens. So that is why I went ahead with desensitization, because normally I usually refuse desensitization most times.
Well, sorry, I'm taking time. We have had 2 patients in whom flow was positive. One was ABO incompatible transplant, T cell flow positive. Anil proved us that this is a false positive, and we went ahead and nothing happened. The other was an flow positive, in which the epilepsy matching proved that it is a false positive again. So very, very rarely, as Ilango rightly pointed out, depending on the immunologist, you can interpret the flow very, very rarely. But
yeah, like for example, if isolated T, or like what sir pointed out, if isolated T is positive and B is negative, you can be pretty sure 99.9999% it is a technical problem, and it is not a true positive. It's a false positive T, and you can close your eyes and do. But then there can be an exceptional case. You have to talk to the immunologist and make sure that it's really a false positive. But if both T and B are positive, the probability of with that both of them being a true positive is extremely high, and you should not even venture. You should not venture. You both are positive, and B alone positive you can do. T alone positive, technical problem you can do, but both are positive. You should keep away, unless the center is very good in desensitization and going ahead.
what happens to all of you when, as we work with the immunologist, our immunology knowledge is coming down, as we don't learn it ourselves, and we depend on the immunologist. And I don't know what
the problem is, we are seeing the unseen. When we were oblivious about all the nuances, we were going ahead with blind approach, and we accept everything. Is that was this, now we are now going from the molecular thing approach. Simply put it in a very thing, we are seeing the unseen. So
very
complexity is increasing every day, and there is no end. That's what we cannot decode God's creation. So somehow whatever we understand, I think we can create an advocacy group, and we can put our ideas together, and we can clarify with some of our friends like Ilangovan, whether we can have some, otherwise everything, it's still a lot of gray areas, sir. So still we don't understand a lot thing about nature. So anyway, whatever it is, today's presentation was excellent. Ilangovan, I should congratulate you for making us understand some of the points. You ignited our thinking in a different angle. I'm really grateful to you for the way you presented today, and both presenters did a phenomenal job. Sir Ramlingam sir, thanks for coming here, and you have created a center in your place where it's going to be. I was talking with Dr. Ilangovan that the immunology center is coming up in a big way, where the Anil was totally committed, and he seems to be very very inquisitive, and is upgrading his own knowledge in terms of transplant immunology. Thanks for everything, sir. And I think Murli has left. Rajarajan's left. My friend I think has work. I thank all the presenters and the panelists, and also the fellow peculiar members who are here, and the MCure people was consistently helping us to create this program running, and we look forward to seeing more and more interesting things in future. Good night.
Thank you, It was very nice. Thank you.
Thank you. Thank you so
once again. Thanks a lot. Very nice.
Thank you, Ilangovan. Thank you, Murli. Thank you, Nayendran.
Thank you, sir. Thank you, sir.